A brief disclaimer, I planned on doing these rounds a while ago, and so things have changed a bit in terms of people's interest in this topic. So our plan for today is to talk about travel history, risk assessment, and investigations, to go over some common pathologies, so malaria, dengue, enteric fever, briefly mention chikungunya, and then discuss a few emerging pathogens of concern, MERS and Ebola. While we will certainly address Ebola, this is not purely an Ebola talk, so if you came here just for that reason, then you can leave and I won't be offended. Hopefully we'll have some good discussion about it at the end, though. I think this is a really important issue, largely because travel is reaching unprecedented levels. Canadians made almost 1 million overseas trips this summer, and more than 400,000 residents of overseas countries visited Canada this summer, which is the highest since record-keeping began. I didn't have statistics specifically for travel in London, but we do know that despite its reputation as a somewhat waspy city, the immigrant population here is almost 100,000. So a lot of people who may potentially be going home, visiting friends and relatives, and returning and presenting to our emergency rooms. In total, about 3% of international travelers present to care for fever. Of Canadians who travel, unsurprisingly, most go to the United States. However, a significant proportion travel to Mexico, Cuba, the UK and mainland Europe, as well as other locations in the Caribbean, mainland China. Hong Kong is on the list of the top 15. Notably absent from that list of the top 15 is West Africa, Sub-Saharan Africa, which perhaps will come as a relief to many of you. Here in London, of our almost 100,000 immigrants, just over half are from Europe. There's about a quarter who are from Asia and the Middle East, several thousand from Africa, several thousand from the Caribbean, and about 7,000 from Central and South America. So keep these sort of demographics in mind when you're thinking about the likely patient who's returned from visiting friends and relatives. So what I'd like to do now is move into doing a travel risk assessment on the patient you see in the emergency department. And this is drawn mostly from this Fever in the Returning International Traveler Guidelines, which are put out by the Committee to Advise on Tropical Medicine and Travel, which is an organization associated with the Canadian Public Health Association. And at the end of rounds, I have a handout, and we'll email it out as well, which is sort of my deliverable, that has the link for how to find that document. It's a really excellent resource for us in the emergency room. So to begin, you want to ask patients about pre-travel preparation. Did they go to a travel clinic? If so, did they receive immunizations, particularly for hepatitis? Did they take prophylaxis for malaria? And if so, what did they take, and were they adherent to it, both during travel and upon return? What sort of protective measures did they use? So that's things like bed nets and DEET, but also if they had high-risk sexual encounters, were they wearing condoms? Specific considerations about air transport, so are they at risk of thromboembolic disease from a long plane ride, and did they do anything to attempt to avoid that? And what sort of environmental risk were they at, and did they take any preparations for environmental risks? So that's things like altitude, potentially diving. You want to ask about their travel itinerary, and it's important that you be specific. So you want dates of travel to approximate the incubation period, which is very helpful in ruling in or out specific diseases. You want to ask about the season of travel, and again, specifically about where the patient went. So were they only in large urban centers, or were they traveling in rural areas? You want to know about their style of travel. So was this a business person who flew into Accra for 5 days, stayed at a fancy hotel and flew out? Or were they sort of a young person, backpacking, healthcare worker involved with direct patient care? You want to know about interaction with the local population, again, potentially healthcare workers and also persons who have returned to visit friends and relatives. And what sort of transportation they took while in country, including the use of animals, particularly things like camels, which might put them at increased risk of MERS. You also want to ask about other specific exposures. So were they drinking the local water and eating street food, which would increase the risk of gastroenteritis? Did they have arthropod bites that they noticed? Were they eating some sketchy meat or dairy? You want to ask about blood and bodily fluid exposure, which is obviously important for Ebola, but also important when you're thinking about hepatitis or HIV risk. So this is important for healthcare workers, but also if people potentially were engaging in high-risk activities while traveling. You want to ask about freshwater activities, which would increase the risk of something like leptospirosis or schistosomiasis, exposures to animals, and if the patient was on safari, which might raise concern about things like trypanosomiasis. The region of travel is really helpful in narrowing down sort of what the risks actually are. So for travel to Sub-Saharan Africa, most common diagnosis is malaria, followed by respiratory tract infections, diarrheal illnesses, and skin and soft tissue disease. Travel to Southeast Asia is commonly associated with dengue fever, respiratory tract infections, diarrheal illnesses, and malaria. South Central Asia is relatively similar, with the addition of enteric fever being a major diagnosis. Travelers to South America are also at risk of malaria and dengue, as well as diarrheal illnesses and respiratory tract infections. And the epidemiology of disease for Central and America and the Caribbean is similar. The CATMAT document describes sort of a review of single and multi-center analyses looking at top specific diagnoses that were made in returning travelers in North America. And malaria accounted for 30% of the diagnoses. It was followed by acute gastroenteritis and viral syndromes, as well as respiratory tract infections. So a lot of this is stuff that we see here and should be relatively comfortable diagnosing. And then some of the less common things were dengue, which accounted for about 5% of diagnoses, enteric fever, typhoid fever, which accounted for about 5%, skin and soft tissue infections, and then a handful of cases of rickettsiosis, viral hepatitis, and UTIs. Now, this data is a few years old. It's from 2011. You'll notice that viral hemorrhagic fever is nowhere on this chart, but I would remind you that the number of cases of viral hemorrhagic fever that have been diagnosed in the US is still a handful. It was 3 when I read yesterday, but changes every day. So still not the most common thing that you're likely to see. The incubation period is probably going to be the other really helpful piece of information in addition to where the person actually went. Short incubation periods are associated with malaria, dengue, gastroenteritis, and respiratory infections. Also associated with rickettsial disease and meningitis. Meningitis is important to think about given that there's a lot of recently returned travelers coming from Saudi Arabia because Hajj happened in early October. Think about meningococcal because there have been associated outbreaks in the past. And then other less common diagnoses include yellow fever, for which there's a vaccine, arboviruses, including chikungunya, and viral hemorrhagic fever like Ebola. When the incubation period is a little bit longer, enteric fever becomes a significant consideration. Again, malaria is right up there. And then other diagnoses include hepatitis, Katayama fever, which is schistosomiasis, liver abscesses, and then some rare things. So viral hemorrhagic fever, which can have an incubation period out to 21 days, as well as HIV, trypanosomiasis, Q fever. And when we look at long incubation periods, greater than 6 weeks, again, malaria is the most common, and malaria can actually have an incubation period of months to years. Less common things, Hep B, amoebic liver abscesses, and tuberculosis, and there are some rare things listed below. Finally, in terms of sort of fever characteristics, the duration of fever is important to think about. Dengue and enteric fever, as well as acute gastroenteritis and respiratory tract infections, are most commonly associated with short duration of fever by the time the patient presents. With longer duration of fever by the time the patient presents, you want to be thinking largely about malaria and enteric fever, with some other diagnoses listed there. Once you've taken a detailed history, and I think really we can do better than like, oh my God, this person was in Africa, which is the initial response, you want to go on to your physical exam, and particularly important is a detailed dermatologic exam. This is a picture of a patient who has an eschar, which was helpful in making their diagnosis of a rickettsial infection. and the patient didn't actually realize that they had this lesion. So really having a good look at their skin, asking about any rashes, super important. In terms of mandatory investigations, all return travelers should have a CBC with differential, liver enzymes, electrolytes, and creatinine sent. And anyone who's returned from a malarious area should have at least 3 malaria smears and antigen dipstick tests over the next 24 to 48 hours. They should also have a minimum of 2 sets of blood cultures, which is most helpful in making a diagnosis of enteric fever, as well as a urinalysis. Supplemental lab investigations are going to depend on your physical exam findings and also whether you're seeing the patient on their initial presentation or representations. Patients should have a stool culture for bacteria if they're having symptoms consistent with gastroenteritis. And if their bacterial cultures are negative and they have persistent symptoms, you could consider a stool for O&P, remembering that this is very lab resource intensive, so really should only be sent if their initial bacteria cultures are negative. Patients with respiratory symptoms should have a chest x-ray. And for patients who have returned from dengue endemic areas, they should have dengue serology sent if the probable incubation period is less than 2 weeks. You can also send an acute serology tube to the lab, which can be held and then paired with convalescent sera if in 2 weeks they still haven't had a diagnosis. In terms of initial management, again, all febrile travelers to malarious areas require repeat malaria screening, and we'll talk more about that in a moment. And patients should be frequently reassessed until a diagnosis is made and therapy is initiated, or until they're subjectively and objectively improving. You should have a very low threshold for admission of pregnant women, patients with immunocompromise, or those with comorbidities. So now that we've gone over the initial approach, we're going to move into a few cases. And rather than pimp just the residents, like we have a lot to get through, so I thought I would pimp everyone collectively. So if you can bring out your phones or computers or whatever device, then everyone will have an opportunity to answer the question. So while you're getting that ready, the first case is a 21-year-old woman. This is typical of patients that I've seen in the department who come in with like a malaria concern. They're concerned, and I kind of looked at her and I was not really very concerned at all. She'd been in Uganda. She's previously healthy. She was, I think, like building a house or like doing some volunteer work there. Her vital signs were essentially normal except for a temp of 38.1, and she looks well. So the first question is, in this well-looking patient, what is the appropriate management? Does she need immediate respiratory isolation, admission to hospital, and an ID consult? Should she be admitted to hospital under medicine pending the results of her screen? Can she go home if her screen is negative with follow-up? Or does she go home with no follow-up required? So what you do is you're going to text to 37607. That's the number you text your answer to, and then text in your answer the corresponding code. Small disclaimer, this is the free version, so it only accepts 40 responses. So if you're slow, you don't get your say. But if you like it and find it useful, let Laura and Dave know, and then maybe we'll have a different version. So 2 more people can get their say in. All right. Great. So this is reassuring because it suggests that you listened to the first 10 minutes of this presentation. So exactly, this well-looking patient, if all her initial investigations are normal, she could go home and be brought back for reassessment. Briefly about malaria. Malaria has 4 human species: Falciparum, Plasmodium malariae, Ovale, and Vivax. And there's a 5th species that can infect humans in forested areas of Southeast Asia, but we're pretty unlikely to see here. They're all transmitted by the Anopheles mosquito, which is a night biter, which is why mass interventions such as bed nets are helpful in preventing malaria, which makes it a bit different from dengue. If you're unsure about whether or not your patient has been in a malarious area, there is actually this really great app that the CDC has. It's a Malaria Map application. So you can type in exactly where they were, like down to the city, and it will tell you whether or not there's a malaria risk, and I believe it also tells you about seasonal risk. And a link to this website is on the handout that I have for you. You can see here areas in Sub-Saharan Africa are all at risk of malaria, as well as Central and parts of South America, India, and other parts of Southeast Asia. I was hoping not to put the malaria life cycle up, but I think a little bit of it is helpful. So essentially, the Anopheles mosquito bites someone and it releases sporozoites into the blood. They then go to the liver, which is why patients who've had malaria for a long time might have hepatomegaly, and then infect red blood cells. And it's this red blood cell infection that's most problematic. So these infected red blood cells essentially sludge in small arterioles and capillaries and cause a lot of the adverse effects associated with malaria and its clinical presentation. Patients generally present with an acute febrile illness with an incubation period of a week or longer. And falciparum causes the most severe form. So patients have high fevers, chills, headaches, myalgias and weakness, and may present with vomiting, cough, diarrhea, abdominal pain, essentially a cluster of relatively nonspecific symptoms, which is why it's important to have such a high index of suspicion for malaria in return travelers. Patients can progress to acute renal failure, pulmonary edema, seizures, circulatory collapse, and death. In non-immune pregnant travelers, falciparum increases the risk of malaria maternal death, miscarriage, stillbirth, and neonatal death. Other species can cause significant morbidity, but are rarely life-threatening. And importantly, Vivax and Ovale can remain dormant in the liver for years. So in a patient who's previously traveled to or lived in an endemic area who presents with symptoms well after the time when they were initially exposed, you should still consider malaria as a possible diagnosis. Here at LHSC, there's a malaria screen module, and it has several components. So it has a CBC with diff, you get a rapid diagnostic test, a thick smear, and a thin smear. So our rapid diagnostic test does two things. It looks for LDH, which lights up on the test as a pan-malaria band. So basically says, yes, this person is infected with some species of malaria. And then there's a second band, which is specifically for falciparum histidine-rich protein 2, and is fairly highly sensitive. And this test does require smears for diagnostic confirmation. Now, one of the issues with this test is they're often trialed in endemic areas where people's parasite burden is often quite high at the time that they have the tests trialed. Here in North America, many returned travelers will have been on chemoprophylaxis or partial prophylaxis. So if they have a lower parasite load at the time that the test is performed, it actually doesn't perform as well and is less sensitive. So these quoted sensitivities are from a paper looking at returned travelers in France, and they're a little bit different than some of the quoted sensitivities. There's a recent Cochrane review that looks at the performance of these tests in endemic areas. So they may not perform as well here in North America as they do in places where the disease is endemic because of this issue of low parasitemia. And rheumatoid factor can cause false positives on these tests. Patients should go on to have thick smears, which allow for diagnosis of parasites and also allow for quantification of the parasite load, and thin smears, which are used for speciation. The issue with these tests is that they require lab expertise. So lab techs who look at malaria smears all day are pretty good at interpreting them. Here at LHSC, I'm not sure how often our lab techs or our laboratory physicians look at malaria smears, but it's at best relatively infrequent and hard to maintain expertise when they're not looking at the tests often. Again, the smears can be negative when the parasite load is high, which is why this repeat testing is really necessary. So the recommendation here is that patients get the rapid diagnostic test and smears, and that they're repeated 3 times within 48 hours. In terms of initial management, patients with malaria need fluid resuscitation, reversal of their coagulopathy, and frequent blood glucose monitoring, because severe malaria can be associated with profound hypoglycemia. In cases of potential cerebral edema, steroids should be avoided because they're associated with increased mortality. Seizure management is with benzodiazepines, as well as glucose for hypoglycemia. And parenteral therapy with artesunate or quinine is indicated for severe infections, and that should be arranged with ID and can also be arranged by contacting the Canadian Malaria Network, who help get the drugs to your hospital in a timely manner for patients with severe disease. Exchange transfusion is also considered for patients with high parasitemia. The criteria for severe disease, which would require admission to ICU and again, aggressive treatment with artesunate, include clinical manifestations, so altered level of consciousness, more than 2 seizures, hypotension, respiratory distress, pulmonary edema, coagulopathy, jaundice, and hemoglobinuria. And the lab findings are a hematocrit of less than 15, hemoglobin less than 50 in children or less than 70 in adults, glucose less than 2.2, acidemia with a pH less than 725, renal failure with a creatinine greater than 265, high lactate, and high parasite load, greater than 2% in non-immune persons and more than 5% if semi-immune. Risk factors for death from the disease. And so someone who has risk factors for death and you're thinking about sending home for their recurrent investigations, maybe someone you should think twice, include patients with comorbid diseases, pregnancy, age. So in Africa and in areas where malaria is endemic, being a child puts you at highest risk of dying from malaria. And the reason for that is children are still developing partial immunity to the disease. In returned travelers, so returned travelers who were not born in endemic areas generally do not have any immunity to the disease. So no one is immune, which means elderly people are actually at the highest risk of death. It's a little bit different from areas where it's endemic. Patients who have taken chemoprophylaxis properly, even if they become infected, are at lower risk of death than patients who have taken no chemoprophylaxis, because partial chemoprophylaxis still lowers your parasite load. As mentioned, immune status is really important. So patients who were born in endemic areas and now have lived in North America or Europe and return to endemic areas often maintain their partial immune status for a significant period of time, and those persons are at lower risk of death from malaria. So while most of the cases that we'll see here are likely to be in African-born individuals, most of the deaths are actually going to be in people like me who might go and stop taking their prophylaxis and then get infected and have no immunity. In terms of disposition, all patients diagnosed with falciparum should be admitted to the hospital, and patients with severe disease should be admitted to the ICU. Occasionally, other species can cause severe disease, so decision to admit to the ICU is a clinical decision rather than one based purely on species. And well patients with Vivax and Ovale can be managed as outpatients with follow-up and consultation with ID. Now, the question of this well person, my question really is, what do we do with them? Do they just come back to the emergency department? How do we get their follow-up? So I spoke with Dr. Ralph by phone, and he suggested that unfortunately ID can't really provide follow-up in this time frame. So patients can return to the emergency department. And depending on if it's a weekday, business day, Monday through Thursday, daytime, the London Travel Clinic may be able to see these people in follow-up. That's Dr. Hemmerberg's clinic, so you can call his office and discuss it with them. His secretary said that they could see people, but it's important that you call and discuss it with him directly before you refer someone, assuming that they're going to get their timely malaria follow-up there. And potentially, if there happened to be an urgent medicine follow-up within a day or two, you could book them in there for their repeat visit. That's all I have to say. Hemorrhagic rash on her belly, her trunk, and her extremities, and it has these sort of little islands that look relatively white. Her investigations reveal a platelet count of 8, hemoglobin of 97, and a white count of 2.5. She has a mild elevation in her transaminases, and the remainder is normal. So the question is, what is the most likely diagnosis in this patient? Ebola, Chikungunya, Dengue, or enteric fever? Is that you, Meg? No. Any stragglers? Okay. Great. So we can stop here. You guys are totally right. This is dengue. So before we talk about dengue, I'd like to touch on enteric fever and chikungunya. As mentioned at the beginning, enteric fever accounts for about 5% of cases made in returned travelers. And it's caused by Salmonella typhi and paratyphi A and B. It's transmitted fecal-orally and is a food and waterborne illness. There's a chronic carrier state possible, which is how typhoid Mary spread the disease famously a long time ago. Most cases are in the Indian subcontinent in Southeast Asia. The disease has an incubation period of 1 to 2 weeks, and the bacteria are intracellular. So unlike the Salmonella we think of, just don't necessarily present with acute gastroenteritis, but rather present with a bacteremia when the bacteria come out of the cells and they get secondary bacterial clinical symptoms. Patients present with, again, fairly non-specific symptoms, fever, malaise, abdominal pain. They may have constipation rather than diarrhea, cough, and weight loss. They may also have hepatosplenomegaly, rose spots, which are small, flat, macular, 3 to 4 millimeters that present on the trunk, and little groups. The pictures that I could find of them weren't very exciting, but if you see them, they can be helpful. They usually show up in the 7th to 12th day of illness. And patients also have classically a relative bradycardia given the degree of fever. So they might be really warm, like 39 and change, but have a normal heart rate. Complications of enteric fever include GI bleeding, intestinal perforation, encephalopathy, and relapse. And the diagnosis is made clinically in conjunction with blood cultures, now blood gastroenteritis. Chikungunya, I wanted to talk about a lot before Ebola became a hot topic, because it's kind of a hot topic in the Caribbean right now. It's a mosquito-borne illness with previous outbreaks in Africa, Asia, Europe, and India. And in late 2013, outbreaks began in the Americas. There's also been outbreaks in Italy recently, and there's thought that potentially global warming is contributing to the mosquito changing, but the vector may also be adapting in ways unrelated to global warming, and international travel may also be contributing. Chikungunya has very high attack rates, so it can be a really large burden to health systems when huge amounts of the population are affected. Typically, it has a short incubation period of 3 to 7 days, and patients present with fever, arthralgias, myalgias, and headache. The main treatment is supportive care. The fever and arthralgias, like the arthralgias especially, can be really debilitating, and in areas where it's endemic, it's actually a major cause of morbidity and disability. So important sort of from a health systems point of view. Also important to keep it on your differential diagnosis for dengue, as they're often in similar parts of the world. Dengue is, as mentioned, really problematic because there's so many infections per year, about 50 million a year over 100 countries. Its primary vector is Aedes aegypti, which is an urban adapted mosquito, and it's a day biter, which makes it harder to control with things like bed nets. There are 4 different subtypes of the dengue. You actually have far more severe disease than if you'd never been infected. So unlike malaria, where semi-immune status confers significant protection, in dengue, semi-immune status actually puts you at increased risk. This is also one of the reasons why developing a dengue vaccine is so challenging. The disease presents with 3 phases. There's an initial febrile phase, which lasts 3 to 7 days, following an incubation period of about the same. And patients present with fever, along with headache, vomiting, myalgias, and a rash. They may have petechiae and hepatomegaly, and also have a mild to moderate thrombocytopenia, leukopenia, and a moderate elevation in their transaminases. They may then proceed into the critical phase, which is characterized by a systemic vascular leak syndrome, hemorrhagic manifestations, and organ failure, as well as severe thrombocytopenia with their lowest platelet count less than 20, and patients then recover. The distribution of dengue, it's not actually particularly endemic in most of Sub-Saharan Africa, but is endemic in the Caribbean, Latin America, Southeast Asia, and India. And again, 50 million infections a year. So think about that in comparison warning signs, which suggest need for admission to hospital and potential for progression to severe disease. And those warning signs are abdominal pain, persistent vomiting, clinical fluid accumulation, so ascites or pulmonary edema, mucosal bleeding, CNS effects, so lethargy or restlessness, hepatomegaly, and an increase in hematocrit, with a decreasing platelet count. And severe disease is characterized by severe plasma leakage, hemorrhage, and severe organ impairment. So that's liver and CNS, as well as cardiovascular. Dengue is managed also supportively, and really it needs titrated fluid resuscitation because patients have such massive capillary leak, and there's potential for significant respiratory collapse. So the WHO has a really nice algorithm for how you should titrate fluids in someone with dengue hemorrhagic fever or dengue shock syndrome. And red cell transfusions and platelet transfusions are only indicated in patients who are actively bleeding. Any questions about dengue? No, everyone's here for Ebola. Okay. So the third case, bad day at triage. So you have 3 patients who show up. I think I heard we have maybe not a lot of Ebola suits and 1 negative pressure room with an anteroom and its own toilet. So you have a 50-year-old woman with fever and diarrhea who came back from Guinea 2 months ago. A 24-year-old man with cough and recent travel who was in Cambodia, and he had recently had a 2-day stopover in Dubai where he got out and saw the sights and then got back on his airplane. And the 21-year-old woman that we discussed in the first case. So the question is, who gets your isolation room and who needs to go there right away? So option A, the patient who returned from Guinea 2 months ago. Option B, the 24-year-old with cough who was in Cambodia and Dubai. C, for some reason, the display is different, so I can't see how many people have actually responded. We'll give it a few more seconds. Okay, so I'm glad to see there's a little bit more uncertainty around this one. And I put this in based, again, on sort of an actual case I had working somewhere where there was a young guy who'd come back from Egypt, actually, and he was in the isolation room, and the person I was working with was like, well, this is ridiculous. Egypt does not have Ebola. We should all settle down, and he does not need to be on precautions. And so he caused a bit of a fuss, and then went in and talked to the patient, and he got a travel history, and it turned out he'd been in Dubai, and when he was in Dubai, he had traveled around a little bit, and the issue with Dubai and someone with respiratory symptoms is that there's a risk of MERS. So then he had to kind of back down and call ID and put the precautions back up. So don't forget about MERS. Ebola has really received all the attention, but 6 months ago we were thinking about this. It still exists. It's a novel coronavirus. There have been 2 imported cases in the US. It's likely not airborne, but there is potential and should have respiratory precautions. And unlike Ebola, MERS can be acquired from asymptomatic persons. So there's been cases of household spread where the index patient in the household tested positive for the virus, but didn't actually have symptoms. So thinking about things like international air travel, the risk of getting MERS may actually be higher than the risk of getting Ebola. There's been about 800 cases so far, and 60 of them were outside of Saudi and the United Arab Emirates. And MERS is associated with a 40% mortality rate. And that's in contexts like middle-income countries that actually probably have reasonably good supportive care. So the 40% mortality rate from MERS may actually be a closer reflection of the actual mortality rate of the disease here than the 70% mortality rate with Ebola in West Africa. The criteria for a person under investigation for MERS, the exposure criterion is a link within 14 days, so 2 weeks, prior to illness onset, which was travel to an affected area, which is most of the Middle East, or close contact with a confirmed or probable case. The illness criteria is fever and new onset of cough or respiratory distress with clinical, radiologic, or pathologic evidence of a lower respiratory tract infection, typically one that requires hospitalization. Although the CDC has recently changed their MERS recommendations a little bit to acknowledge that atypical presentations with milder disease are possible, and so it should still be considered in patients with milder presentations. Any questions about MERS? Okay. Can you guys read that? So this is a little bit old, but I think captures still some of the sentiment. So Ebola first appeared in 1976 with 2 simultaneous outbreaks in Sudan and the DRC. The current outbreak of Ebola began in 2013 in December in Guinea and is the largest and most complex Ebola outbreak since the disease was identified. Currently, Guinea, Sierra Leone, and Liberia are the most severely affected. There's been a controlled outbreak in Nigeria and an isolated outbreak that's unrelated in a remote part of the Democratic Republic of Congo. The Nigerian outbreak is actually pretty interesting. They had a patient return, and in total, they had 20 cases with 8 deaths. And they managed to do complete contact tracing on 894 persons under investigation for the full 21 days. They all finished their follow-up, and I think demonstrates that with an appropriate response, a country in Sub-Saharan Africa was able to effectively control their outbreak. And Nigeria has been lauded to some extent for asking for help pretty early and being very aggressive in their response. And while they certainly have more resources than Sierra Leone and Liberia and Guinea, it does demonstrate that this can be controlled potentially in a sub-Saharan African country, which is also really important to know given that there are a significant number of migrant workers in West Africa who traditionally at this time of year return to East Africa. And so the movement of Ebola from persons in that way is not unlikely. Ebola's natural reservoir is fruit bats, and it's transmitted to people. It's thought to be initially transmitted through the consumption of these bats, and that is spread among people once they become symptomatic through bodily fluids. It has secondary reservoirs, which include non-human primates, which are sometimes also consumed for food in parts of sub-Saharan Africa. The disease has an incubation period of 2 to 21 days, and that 21 days includes like a threshold of safety. There's a margin of error built in there. So it's not that the actual latest report of anyone's transmission was 21 days. That includes a built-in margin of error when we talk about 2 to 21 days. It's spread through direct contact through broken skin or mucous membranes with blood, bodily fluids, or the secretions of an infected person or environment. So patients' linens and clothing in the room of someone who's affected with Ebola are also potentially infectious. Critically, a person is only infectious when they're symptomatic. which is a message that I think is become increasingly confounded in the media. Patients do continue to shed the virus after death, which is why burial practices have been responsible in part for spreading the virus further. And after recovery, the virus can be transmitted in semen for up to 7 weeks, so patients who've recovered are encouraged to use condoms or abstain from sex. Again, asymptomatic patients are not contagious. This is a CDC infographic that I altered a little bit. Just again, you can't get Ebola through the air or through the water or through food, although despite that, it is recommended here at LHSC that you wear an N95 mask if you're seeing a patient with suspected Ebola. The CDC case definition for a person under investigation is someone with fever and additional symptoms who also has epidemiologic risk factors. That's the key, again, going back to the travel history. So within the past 21 days before the onset of symptoms, they must have had contact with the blood or bodily fluid or human remains of a person known or suspected to have Ebola, or be a resident in or have traveled to an area where Ebola virus transmission is active, or have had direct handling of bats or non-human primates from endemic areas. In terms of the disease, the hemorrhagic symptoms typically begin 4 to 5 days after onset, and it's manifested by hepatic, renal, and CNS manifestations, with patients dying of shock and multi-organ failure, usually at day 6 to 16 of their illness. The obvious and significant concern is that the case fatality rate is so high. It had been reported at 50% and then actually just got, in the last couple days, changed up to 70%. And the reason for that is the previous models weren't accounting for patients who were infected but had not yet died. And given the exponential spread of the disease currently, there's so many people affected who are currently infected but have not yet died, although they are predicted to die, that the case fatality number of 50% that only accounted for the actual deaths was a significant underestimate. And important to remember that that case fatality rate is in a very, very resource-poor part of the world and may not be an accurate representation of the case fatality rate with the resources available here. So LHSC, there was an email, LHSC has a plan for Ebola. So this is sort of the process map for suspected Ebola in the emergency department, and there's a link on the handout for where to find this. And I believe there are also in-services coming on Ebola. Some have potentially started already. In terms of key emergency department actions, if you can't read this, the most important thing probably is screening right at the beginning for fever and travel history, which is in this flow map to be done by the clerk, but should also be done by the nurses and should also be done by the physicians. And the other really important part here is that then the person who obtains that history tells someone face-to-face right away. And this is one of the errors that was made with that initial Texas patient, is they were identified as having potentially traveled to West Africa by the person who triaged them, who then I believe wrote it in the chart in a place that was inaccessible to the physician, didn't tell anyone, and then the doctor didn't ask. So if you have a concern about potential Ebola, it should be a stop what you're doing, go face-to-face and tell the epic doc, and proceed from there. Make sure the charge nurse knows and make sure the emergency physician knows. The charge nurse is responsible for ensuring that infection prevention and control as well as security are paged, that the staff are notified and that there's PPE outside the door, that the patient is placed in the negative pressure room with anteroom and their own bathroom, the precautionary signage is placed, and there's a charge nurse checklist that needs to be completed, as well as a security checklist. Importantly, the only physician who is to enter the room is the emerge doc. No house staff are supposed to enter the room whatsoever. And after their initial assessment, if they continue to have concern about Ebola, the emergency physician is to directly page the ID consultant on call and have a consultant-to-consultant discussion about the concern. So that's the current process map that's outlined, or at least the very most recent thing I could find. And I think, again, critical steps really is that very initial screening so that a person who has a potential Ebola risk isn't sitting in the waiting room for 10 hours with the rest of our patients. 2 brief quotes to end on. This is from Paul Farmer and Jim Young Kim, who co-founded Partners in Health. The Ebola crisis today is a reflection of longstanding and growing inequalities of access to basic health care. Guinea, Liberia, and Sierra Leone do not have the staff, and systems required to halt the outbreak on their own. Liberia had just 50 doctors working in public health facilities servicing 4.3 million people. To contain Ebola in North America requires an adequate response to Ebola in West Africa, and that's something that MSF has been asking for help since March and recognizing this as a concern. And I heard a quote yesterday, the world is responding in bureaucracy time and Ebola is changing in virus time. So until we start responding in virus time, we won't get control of this outbreak. And finally, this is a quote from Greg Gonslaves. Some epidemics are unavoidable, but many are a result of crumbling health systems, economic inequality, local kleptocracies, and global power dynamics, which perpetuate an ongoing cycle of fresh outbreaks of new and old diseases. Until we address the issues of social injustice, we'll not be doing enough to make a real difference over the long term. We'll treat the symptoms, but not the real cause of what ails people. So on that note, I'll end and open it up to discussion.
Kate, thanks very much. That was a great overview of what we frequently see at the urgent care clinic and walking to our urges, especially around the time that people are traveling in winter months and going to warm climates. I wanted to ask a little bit about dengue fever. Often, I don't think there's a stat test for that, and so often we sort of clinically suspect it, maybe a little bit of low platelet count, maybe a little elevated from liver enzymes, but they look relatively well. What's your suggestion of how to manage those patients?
Can I defer? Yeah.
I'll answer that question. I'm a pediatrician, but you guys all know this. So what I would do with a patient like this, dengue, doesn't matter if you make a specific diagnosis or not per se, because it's purely symptom management. So in a patient that you have a high index of suspicion, you have them come back in 48 hours with repeat blood work and another assessment. That's the best way to do it. Because if their blood work is abnormal, then it's what you would usually admit with. So low platelets, iron or BPT wrong. The patient's clearly going to be pending sort of sepsis, like they look sick. With dengue, you get this, they're a bit sick at the beginning, then you have a plateau, and then they have this crash around day 8 or 9. So that's an important thing to sort of be aware of. So the most important thing is ongoing good care. I'm hoping that now that we have more adult ID people here, there'll be this urgent adult ID clinic, because that's really we should be following that.
Yeah.
Send them to cellulitis clinic.
Only if you have dengue in the lower leg.
Any other questions for Kate?
Yeah.
I have a question. Again, thanks, this is great. I have a question about Ebola transmission. It may even be silly, but we keep hearing that it can be spread through body fluids. And so you want to isolate a person in a room that has its own toilet. But how long is it? 7 days? Like if someone then urinates or defecates into the toilet that goes into the general septic system, is that potentially a route of transmission, or it's no longer active?
Sure.
So that actually, it's always gone in the regular system, and it's thought that unless you have incredibly bad sanitation, that is not a route. But very interestingly, that's actually being raised at a provincial and national level in Canada, because part of the reason that we can't do lab testing is actually because when we do lab testing, we just flush that down into the system. It is probably very non-infectious that way, and realizing that we have bazillions of infectious diseases like hepatitis A that also need sanitation, and yet we don't see an increased risk in sanitation workers and that sort of a thing in North America. So I think that is a very limited route. The question that often people bring up, I've read that it's in semen as long as 7 months. So there's that, what you do with the people in the home and all that kind of stuff. Personally, I would have no sex with that person for about 5 years. But
Any other questions?
Can I just?
Harry? Sorry.
Just one follow-up on what you said about the dengue patient is does not look like they obviously need to bring them back or maybe for us to get
Urgent medicine.
follow-up with someone in the community. Does public health, if you're suspecting something like dengue fever, does public health need to be notified?
That's actually a great question.
too.
All of notifications are supposed to be on clinical suspicion, so we're supposed to call them chickenpox and pertussis, and I know we all do regularly. I'm actually not all that sure. If it's not infectious to other people, they would be that worried about it. That's a good question. I'm not 100% sure of what the right thing to do is. I did want to bring up just the whole thing about people going to Africa with malaria that I think is really helpful. So as you know, if you're born there or you've been there a lot to get the STEM immunity, it takes 8 years to lose that immunity. So that's actually the most at-risk patient is someone, most of our deaths would be people who are generally Nigerians, because you can see that Nigerians is a wealthier, better educated country. They come to Canada, they work. They're there about a decade, and then they want to go back and visit their family. And what happens is there's usually 5 or 6 kids, they don't seek medical care, they don't think that they need malaria prophylaxis, it costs them about $1,000 to go to a trauma clinic and get it for their whole family, so they don't seek care. And in the ID world, we call these patients in a sweet way Oreos, and I say that to them, you're black on the outside, but you're white on the inside, because they actually perceive themselves as being at no risk because they're from Nigeria. And that's actually the Canadians that we lose, is those ones who go back because they've now lost their STEM immunity. So it's 8 to 9 years that you lose your STEM immunity. Whereas dengue, which Kate just pointed out, is actually the opposite. The more times you get dengue, the sicker and sicker you get because it's an immune phenomenon. So it's usually the person who goes every year on a vacation to somewhere in the Caribbean. Really unlikely person who went for the first time and did the whole Vietnam packing or something, backpacking trip and came back. So those I think are some somewhat helpful ways to look at it.
Thank you.
Any other questions? Scott?
Why is travel medicine not covered by OHIP? Because if you look at the cost down the road of having a very ill traveler come back means ICU admission, that's going to be way more than it costs to vaccinate people and do some preventive medicine.
Absolutely. And no one would agree with you more than ID doctors. So it was covered at the beginning of my career, and then it stopped being covered. There was a massive outcry, and we didn't win that one. So I know, Scott, how completely politically active you can be. Write a letter to your member of provincial parliament.
Oh, I'm having dinner with her this afternoon.
This is just because it was not a strong enough voice, and it wasn't enough people who outright say, if you can afford to travel, you can afford to cover it. Too bad for you. It was delisted at the same time with a bunch of other things like circumcision and things that were
Yeah, I'm mad about that too.
It's too late for you, Scott. Are there any other questions?
Kate, I just want to share with everybody an experience I've had about 3.5 weeks ago, which is why I just want to thank you for this presentation because it's extremely timely. I wish I had had it before 3.5 weeks ago. So I was working one evening, Trevor Gilkinson was the other emergency physician at Victoria Hospital, and I was the epic doc, quite unfortunate for me that night, when the charge nurse came to me and said, Karen, there's a male patient at triage who has a temperature of 39.5, who's just returned from Africa, literally just returned, had gotten off a plane in Toronto and had been driven by a family member back to London and immediately to the hospital based on symptoms and fever. The patient was in the waiting room for more than 2 hours. There were no respiratory symptoms, but sat in the waiting room unmasked around other patients for more than 2 hours. The isolation room, thankfully, did not have a psych patient in it. So the patient was brought into the isolation room. And the question for me was, oh dear, could this person be somebody who could possibly have been exposed to Ebola? So the patient, thankfully, on travel history, had been in East Africa, but did go to Nigeria for a short period of time, realizing that that's only a localized exposure, but then traveled back to East Africa before coming back to Canada. So there was a connection in the travel history that was of concern. He had multiple physical symptoms in addition to fever that would fit with a concern for Ebola. So it's about 11 o'clock in the night. And so I say to the charge nurse, well, what's our policy? Who do we phone? So we look at it. It's quite confusing at the time. We ended up calling the infectious disease consultant who was on call, who basically had nothing to offer. And then subsequently called public health. In fact, we were told that the Ebola meeting hadn't yet happened. So keep the person in the isolation room and good luck to you. So my question as the epic doc that night is two things. First, the patient had sat in the waiting room for 2 hours, so the charge nurse appropriately said to me, well, goodness, Karen, what do you think about all these people who were in the waiting room? For which I really did not have an educated answer. And the second thing was we put the PPE, as per usual, outside of the room, which included our usual gear, but of course would still have exposed skin. So now we have people, whether it's the sacrificial lamb, who's the emerged staff doc, who goes in to see the patient, who is going to put on full PPE as per our protocol, but still has exposed skin. So if you had a cut on your neck, you took off your PPE, you did it inappropriately, there was a splash of contents that went on your skin, potentially, you know, you can address this, is what do we actually do when we experience a patient like that with regard to gearing up with our PPE? Because it didn't appear that what we had available to us that night was necessarily the appropriate equipment.
Excellent question, and I remember hearing about that patient. I think I got a call at some point in that case as well. So the new PPE, we now have tie-back suits and the appropriate suits, and the advantage for the tie-back is the zipper area is covered over. It's just that there'll be training starting next week for everybody. It takes time to get bureaucracies mobilized, right? When we first heard about Ebola, how many months ago was that, Alex? And we started to get at least some kits. And we actually, there were kits made up specifically with the waterproof surgical gowns, because that was, we were told. I had a long discussion with ID, and they said, oh yeah, the yellow gowns are fine. And then Marina and I talked, and we said, no, the yellow gowns aren't fine. So we've made some modifications. The new suits are coming, the training for those suits are now coming. From the standpoint of, and we were taught how to gown, and it's called doffing, taking it off. And security will be trained to observe your gowning and doffing if you have a suspected case. Because that's the greatest risk to you, is actually at the doffing time when you're taking it off. And I think that may have been what happened to the unfortunate nurses in the States, but we're not quite sure. We're obviously not privy to all the information with regard to those individuals. With regard to the other aspect, then it becomes a public health mission. And you know, public health is kind of a vague entity for us in a lot of ways, right? I mean, we do get the rabies vaccine and a bunch of other things. But in reality, one of their specialties is disease tracking. So if in fact that patient had Ebola, then they would have done a public health methodology, and Kate maybe can talk a little more about this in her education, to track down all of those in the patients exposed. So, and then they would have done all of the same things they did in Texas. And eventually they would isolate all these individuals, and everybody they were in contact with, if they were asymptomatic, it doesn't matter if they were symptomatic, by the time the realization this patient had Ebola, then all of their contacts would be isolated. And in the case of Texas, as you know, they actually had, I would say, armed guards, because these patients refused to stay isolated, at least part of the family did, so that they will take a response on like that. The same thing with everybody in the emerge who could potentially have been exposed at that time. They would, from day 2 to 21, they would undergo isolation until they were proven not to be disease carriers. I don't know if that answers your question.
I think the one point, can I bring up the one point that is the difference between what is, I call infectivity, but contagiousness versus infectious dose is what is really being, Barack Obama got it though, because he talked about it last night. So, for example, if somebody with Ebola came in here right now and walked all around and sat beside us, and even no matter what, probably none of us would get it. It is not very infectious unless you have any direct contact. But what it is, so that's a contagiousness, but it is probably the most infectious organism known to man. That is, if you get a single virus on your skin, one virus is considered the infectious dose. And we don't know if it needs to go through a breach or a cut or a mucous membrane. That is not known. So it's actually very important. And I have to say, like, I was not part of those discussions either. But I personally feel I would not go in with any millimeter of exposed skin. No, 1 millimeter of exposed skin. And I think we're on top of that now. We're getting better at it. To be very fair, no one in the world has figured out docking very well. You can look up Sanjay Gupta. He tried to do it. He wasn't even able to do it on CNN without contaminating himself. I spent several hours last Thursday morning. I have never used a suit before. So this is not something that's actually easy to do. I think we all are going to have to learn. And I actually am very sure that even at CDC and at Public Health, they're not 100% sure of how to dock 100% effectively with the suit. It's hard to do. But the issue is not, I'm not worried about people in the waiting room, but I think we should realize that it's very, very infectious if you get a virus, and that's a big difference. So what my personal opinion is, we've downplayed a little bit too much that, oh, now don't worry, it's not too infectious, because that's been a huge public health message, certainly in the US and other places, WHO, and we've not quite given healthcare workers that understanding of the infectious dose.